Okay, good morning all. First of all, I congratulate the organizers, that is Baburaj, Ashish and Binil and Arun. What is new? I haven't seen. And Arun, as well as the ISA Thrissur city branch for conducting a academic session like this for our technicians. And a very warm good morning to all once again. This is the place. I am Dr. Shamshad Beegum. I am working in this medical college, MES Medical College, Peripheral. So, I will be dealing with what are the things that are required before we start with the peripheral nerve block. Because you all know that you are the people who are helping us in throughout the procedures. So, what are things has to be arranged before we start with a peripheral nerve block? I will be discussing under these headings. So we can start with what's a nerve block. And at the end, shall I ask some questions, because I will be talking only for 10 minutes. All of you can come in front. So a nerve block is injection of local anesthetic near a nerve or the specific, that is the specific nerve or the plexuses. So what can be the indications for giving peripheral nerve block? That is to decrease the pain in certain part of the body, especially in the pain and palliative care patients where they have intense pain. We can go for peripheral nerve block to relieve the pain. That is to relieve the symptoms, and it is very useful in palliative care patients. That is pain relief to a specific area. And the second one in the perioperative period is to provide anesthesia as well as analgesia as well as the postoperative analgesia. So it is better to avoid deep sedation while performing peripheral nerve block because it requires close monitoring of the patient. So the advantages of peripheral nerve block are the patient will remain awake and they can communicate to us what are the difficulties that they were facing. And there will be increased patient satisfaction, improved quality of recovery when we are combining it with the general anesthesia, decreased opioid use as well as the length of the stay in the recovery room, and the disadvantages are the duration of the block time. So usually, and when an expert is doing the nerve block, it will take about minimum of 5 to 20 minutes for giving the nerve block. And with the arrangements and all, it will take a minimum of about 20 to 45 minutes. So what is the problem with that? That will be prolonging the duration of the surgery time, because the number of regional procedures are increasing nowadays. So it can prolong the duration of the whole of the operation time as well as the working in the operation theater. So to avoid that, a block room concept was introduced. That was introduced in North America in the last decade and in the UK recently, but still we have our block room setup also. I think so. I think that is continuing now also. The advantage is that the surgery the block can be performed parallel to the surgical procedures that are going on. And where should be the location of the block room? It should be in the OT itself. And what are the equipments that are required in the block room? That is just like any other OT setup. We require the oxygen source, the anesthesia machine, and the airway gadgets. And the emergency drugs, including the lipid emulsion, the crash cart with the defibrillator, and the resuscitation equipments and the suction apparatus, just like anything before we start with any anesthesia. So this is our OT room, block room concept, and this is our technician. He is Ashwin. So he is the one who is assisting us while performing the block. Not every day they will be changed. And so these are some of the common blocks that we are performing, and all of you may be familiar with this. And that is the upper limb blocks, the lower limb blocks, as well as the truncal blocks. All these are the blocks that we are performing. So the requirements of nerve block is just like requirement of anesthesia itself, because we are giving large dose of the local anesthetics that can produce some of the complications also. So we require the ASA monitors itself. The standard basic ASA monitors are required, like, what are they? The pulse oximeter, ECG, non-invasive blood pressure, as well as ETCO2 also should be made available before we start with any block procedures. And there should be an equipment card. The equipment card should include emergency drugs as well as the airways, and also all other associated things like to sterilize the area, including the marking pen as well as the block, other equipments like that I will be coming later. That is, the marking pen should be there, and where to puncture the nerve blocks. And also we need the nerve stimulator as well as a portable ultrasound machine. And the catheters to infiltrate the local anesthetics for continuous infusion, as well as what local anesthetic that we have to set in the OT when we perform the local anesthetic, peripheral nerve blocks, and the drug for the management of the complications. And it is a must, a trained nurse to monitor the patient's vitals. And I don't think the nurses, because of the scarcity of the nurses, they were not available. That's why we have started the OT technician course in 2010. This is the peripheral nerve stimulator for nerve location. All of you might have seen it. So the advantage of this is the older version. Nowadays we have got more advanced version, and there should be a needle. This is the needle. In this we can't see that needle. That is the insulated block needle, and it is connected to the pulse generator, that is to the current. And also the peripheral nerve locator, that is the lead to be attached to the which is the site to be blocked, and also the syringes with the loaded syringes with the local anesthetic. So this is the one that is available to all of us now. That is, if we are depending, all this depends upon the block, where to be the site of block, as well as the nature of which block that we are going to perform. This is the catheter for the continuous infusion of the drug. Usually we have to start with a current of about 2 milliamperes when we start giving injection, when we start to locate the nerve, and it should be reduced to 0.5 milliamperes. Then only you have to inject the drug. Most of the time you are the people who are adjusting the current level and all, and it should not go below 0.2 milliamperes, because once it goes into the nerve, that is in the interfacial, if we can't identify it, and it will be damaging the nerves. So we have to be very careful when we select the current, and most of the time I think it is with the technicians now. This is how we are performing the nerve blocks. That's why I, along with all other sponges, the drape areas, the whole towel, along with that, we need a marking pen where to puncture. So the second one is the ultrasound guided nerve block. So this is the ultrasound guided nerve block. The advantage is that the volume of the drug that can be reduced by seeing the site of the injection, as well as the expansion of the drug that we are seeing around the nerve. We can reduce the volume of the drug to be injected, as well as we have to closely monitor how it is performed. That is the site of the path of the needle that is going around the nerve like that. So all of you might have seen the USG guided nerve block, isn't it? Isn't it? Everybody might have seen. Okay. So this is the block room setup. That is the monitors. The anesthesia machine will be there. The emergency cart with the emergency drugs. Everything is there. And we have to, and you are the technicians who are asked to bring all these things if it is not arranged properly. So this is the USG guided USG machine, and the air gadgets and all these are arranged in this cart itself. So how will you prepare? What are the preparation of the patient? We have to get a consent to perform the nerve block after performing the procedure to the patient as well as to the caregiver. And also a written informed consent should be made available. And the fasting guidelines are just like any other surgeries. And also an IV access should be there. And the complications of the nerve blocks, that depends upon the drug, the type of the drug that we are using, the volume of the drug that we are injected, as well as the site of block. The complications are divided into acute and chronic. The acute complications are allergic reactions, as well as hematoma and local anesthetic systemic toxicity. For that, we have to require that emergency cart with the drug cart also, with all other accessories that we require. And the chronic complications are, and the acute allergens should be treated immediately with the steroids as well as the adrenaline as well as the local anesthetic systemic toxicity that will be coming soon. And the chronic complications are nerve injury as well as the local site infection. The local anesthetic systemic toxicity, the drugs that are causing are bupivacaine, levobupivacaine, bropivacaine, as well as lignocaine, among which lignocaine is the least one that produces complications, and the lipid emulsion is for the treating the cardiovascular as well as the central nervous system symptoms. And these are the symptoms that are produced first. Once it is affected, that is the central nervous system is affected, the patient will be complaining about the perioral numbness, the dizziness, as well as the lightheadedness, and all these will be there, and it will be conveyed most of the time to the technicians as well as the doctors that are available there, and we have to be very careful about it. And the treatment includes control the seizures as per the ASRA guideline, American Society of Regional Anesthesia guidelines. We have to treat with the benzodiazepine, but once it is in the OT, we have to manage with the barbiturates and stabilize the circulation, arrhythmias, and cardiac arrest with the advanced cardiac life support, and decrease the serum concentration of the local anesthetic with the intralipid. That is the specific treatment for the high volume of the local anesthetic that we are injected into the patient. And the dose is 1.5 ml per kg over 1 minute. Continue the infusion at a rate of 0.25 ml. And all these things will be done by the doctors itself. Only thing is that you have to check that it is available. That is the 20% intralipid is available in the emergency cart as well as in the block room or in the operation theater, wherever it is available. And once it is used, you have to tell the doctors to replace it. The recommended upper limit of emulsion is approximately 10 ml per kg over the first 30 minutes. So to conclude, what are the things that I have said? That is nerve block. All of you might have understood, isn't it? What is it? Can anyone answer it? I think some of the students are from outside Kerala, so that is why I explained everything in English. So nerve block is injection of local anesthetic around the nerve as well as around the block. So block room concept that was introduced recently to reduce the surgical time in between. we can conduct the block parallel to the surgery to reduce the surgical, that is the operation time. Then equipment for nerve blocks should be arranged properly so that if any problem occurs, we have to get it rapidly. And the complications of the nerve, there are both acute as well as chronic complications are there. And the local anesthetic, systemic toxicity and the treatment you have to study because it should be written as well as it should come for the theory exams also for the technicians also. So that is the significance of that. And that are the conclusions. So this is the, for your doctors, you have to go back to your college or the hospital, wherever you go, and convey that we, the doctors or the anesthesiologists are conducting the South Zone PG Assembly as well as ISA Midcon at Malappuram. That the venue is at MES Medical College, Peripheral. Thank you all.